All right, everybody, welcome to the second webinar. My name's Dan. I'll be moderating this one. And then what I'd like to do is have everybody who's in the room, the non-platform team members, go around and just introduce yourselves so Mary knows who's here. So we'll start just from the top of the list. Can Abhay and Zahir, can you guys just unmute and introduce yourselves? Tell us what project you're with.
Hi, everybody. We here are three people, myself, Abhay, Zahir, and Manoj as well. We are from India, and the project is scaling early childhood development through Anganwadi centers, that is ECD, Early Childhood Development Centers in India. Thank you.
Great. And then Daniel, do you want to unmute and introduce yourself?
Yeah, I'm Daniel. I'm leading the STEPS project here in Brazil. It's an early childhood intervention, center-based intervention that aims to promote motricity, has also special modules of music and art, and has proven to be effective in non-vulnerable contexts, but we are trying this now in very vulnerable situations. And we also have two treatments in our intervention, one with no supervision that should resemble more the context in which we scale up the activities. So thanks everybody, and good morning.
And then Gertrude, do you want to unmute and introduce yourself?
Thank you. I'm Gertrude Namazi. I'm the principal investigator for the study being conducted in Uganda, which is titled Strengthening Health Systems for High-Risk Babies Care, which involves, there are three strategies where we want to have improved identification of the high-risk newborn babies through use of a foot measure card and a danger sign screening card, and then improve the quality of care at health facilities through training of health workers and mentorship and support supervision. And the third strategy is the follow-up of those babies until up to about 15 months. Thank you.
Great. And I think we have some new people. So Jamie and Anna, do you guys want to introduce yourselves? Jamie, you want to go first?
Did you say Jamie?
Yeah. Do you want to introduce yourself? Because I think Gertrude hasn't been with us before.
Oh, okay, sure. No, I thought you said Jim. Yeah, I'm Jamie Radner. I teach at the University of Toronto, and I'm a member of the platform team. I feel like, since I don't think we've done it yet, we also ought to introduce Mary De Silva, who teaches.
Yeah, I was going to wait till the end. So yeah, you're more than welcome to introduce her if you want.
Well, Mary teaches at the London School of Hygiene and Tropical Medicine, and a large focus of Mary's career is theory of change, especially in the area of mental health interventions globally. You'll see some of her, it's easy to find various of her papers on theory of change in that context. She does wonderful work, and we've been lucky to engage her as a consultant to our platform. So we don't have her on all of these calls, but she's a guest lecturer and consultant for purposes of theory of change. And so welcome, Mary.
Right, so I think we just had two people join. Ranadip, can you just introduce yourself for the rest of the group?
Yeah, myself, Dr. Ranadip Chaudhary. I am from Society for Applied Studies, New Delhi, India.
Great, thank you. I'm going to mute you so we don't hear or see you during the presentation, okay? And we just had somebody join by phone, the 989 number. Can you just introduce
Yes, hi. My name is Jay Stapleton, and I'm the Monitoring and Evaluation Officer for Heartland Alliance International.
Great. Thank you. All right, so one note, we talked about this last time, but if you have questions during Mary's presentation, for those of you who are using Basecamp who are actually on the computer, you can use, there's a little kind of it's like a chat button up in the right-hand corner of your screen. If you guys want to enter any questions you have during the session into that, and I'll be monitoring that, and Mary will also be stopping during specific times in her session to take questions. So as the session is ongoing, instead of asking a question, please use that. All right, and Mary, go ahead.
Hi, well, thank you all for coming and welcome. So I've not actually done a webinar before, so I do lots of face-to-face teaching, but I've not done it electronically or virtually like this. So apologies if it's bear with me rather. So because there's a nice kind of sized group of us, I'm very happy to make it quite interactive and have comments throughout. And as Stan said, I will be stopping at particular points to ask questions. So I don't want you to be sitting there wondering what on earth I'm talking about. I'd rather you flagged it and I explained as we went through. So today it's really about understanding the use of theory of change to design and evaluate complex interventions. And I'm going to focus today much more about the designing side of designing interventions using a theory of change approach. And then the second webinar, which is in September, will be much more about how you then refine that theory of change and take it through an evaluation process. So today we'll be covering what is theory of change, how a theory of change map can be constructed, and then how you can become a theory of change champion for your project and really use theory of change as a method, as a framework throughout your project. And then the second webinar is about, as I said, formative research and piloting and process and outcome evaluation. So what is theory of change and why do we need it? This little cartoon is quite a nice description of what we often do when we're designing and evaluating complex interventions, such as the ones at Saving Brains. All of the Saving Brains interventions are complex. And it's the idea that we don't really know what happens in the black box inside the intervention. Some kind of miracle occurs. And what theory of change really tries to do is unpick the causal pathways through which an intervention has its impact, and then evaluate all of those stages of the pathway to unpack the black box. So really all that theory of change is a causal pathway which is empirically tested. It's not magic, and it's very logical and hopefully quite straightforward to use. So a little bit more detail about what theory of change is. As I said, it's this causal pathway. It was developed in the States, in the US, in the kind of 1980s, and it was really meant for designing and evaluating complex community initiatives. And it's been taken on quite a life of its own in recent years, and many funders are now requiring you to do theory of changes, of which Grand Challenges Canada is one of them. Many other funders, Gates, for example, now also very keen on theory of change. And the reason they're keen on it is because it provides a very transparent way of showing what intervention you're doing and showing the impact of that intervention. So these are the kind of people that are using it at the moment. As I say, lots of NGOs use it. Donor agencies such as GCC use it to demonstrate the impact of their projects. I work very closely with the Global Mental Health stream within Grand Challenges Canada, and we're using theory of change to evaluate the impact of the whole portfolio of funding. And I also use it in projects such as the Saving Brains projects that you work on, so individual interventions, for example, in RCTs or in non-randomised evaluations of individual interventions. So you can use it for many different levels of intervention. So it's similar to other types of ways of managing a project or of describing an intervention. So things like driver diagrams, logic models, log frames, project cycle management. The theory of change sits within that type of tool. But I think it's much better than any of those things for a number of different ways. A number of different reasons. The first is that it's generated through stakeholder consensus. And I'll take you through the process of how you generate that consensus in a theory of change workshop later on today. But it enables you to, right at the start of your project, enable your stakeholders to actually have a say in how the intervention is designed and evaluated. And that can be quite powerful for generating stakeholder buy-in. Secondly, it's very much embedded in the context that the theory of change really comes from the ground up, and as I say, it's generated by stakeholders. So it's very difficult to have, it makes it much easier rather to design an intervention which comes from the context rather than one which is flown in. It acknowledges the complexity of change. So a lot of these other things it's similar to, such as a logic model or project cycle management, they impose a structure upon your intervention. So for example, it's cyclical, or in a logic model, it's a linear relationship. But in theory of change, you can have, your diagram can look like absolutely anything. It can reflect the true reality of the pathways through which your intervention works. It's evidence-based in that every stage in the pathway is empirically tested through your evaluation strategy. And it doesn't just measure activity, such as a log frame does, for example, how many people you've trained. It also measures change, whether that activity has produced the right change. So, for example, how many people you've trained, but whether they've actually got the skills they need in order to deliver an intervention effectively. As I say, it can be tested because you have specific indicators for each stage of the pathway, which you then test. And it can also represent change at many different levels. So you might have activities in your intervention which happen at the community level, in the facility level, you might have district level changes, and all of those different levels of activity, those different components of the intervention can be represented in your theory of change diagram. So I'm now going to take you through a very simple example. I'm going to build up a theory of change map so that you see through a kind of very simple, facile example, really. And the aim is so that you understand the different components that make up a theory of change map. So the most important thing about theory of change is that you start with the impact that you want to have in the real world. So most of the time when people design complex interventions, they think about what they want to do rather than what they actually want to achieve. So an example of that would be, I would like to deliver cognitive behavioural therapy to mothers. And they don't think, actually what I'm trying to achieve is to prevent or to treat maternal depression. So start with the change you want to make in the real world. And in my simple example, I've decided that the impact I want to have in the real world is to make my friends happy. So that's called your impact. And I'm sure that all of you will have created an impact statement for your RMAF anyway with Grand Challenges Canada. So that's really a question of plugging in the impact that you've decided that your project is going to have. And then you start a process of building up the pathway through which you are going to make your friends happy. And that pathway will be defined by the type of intervention which you're going to do. So I've decided, having searched literature, for example, that one of the things that make people happy is good food. So my broad intervention that I'm going to use to achieve my impact is to have a dinner party. And I'm now going to build up the steps through which having a dinner party creates happy friends. So first of all, I need to start with some intermediate steps. And these intermediate steps are called intermediate outcomes, effectively. So the first steps are really the inputs, the things that you need to start off with. So first of all, we need to have money to buy food, and we need to have friends to invite. And without those two intermediate outcomes, those two preconditions, we can't have a dinner party. Oops. The next thing that we need to do is to have some interventions in order to turn those inputs into something. So these are starting to build up the different intervention components of your complex intervention. So firstly, once I have money to buy food, I need to do an intervention, which is go shopping and buy food, or I need to send the invites to my friends. And then that leads to the next stage of the causal pathway, which is that there's food available to be cooked and that invites have been accepted. You can see how we're starting to build up the causal pathways. And at the moment, we've got two separate streams of activities which need to happen, one which involves friends and one which involves me doing something to cook food. So the next stage of interventions is that once I've got the food, I need to then cook it. And my friends, once they've accepted the invites, they have to travel to the party. Now, at this point, there are some assumptions which come into play. And these assumptions can be anywhere in your pathway, and they're effectively the barriers which you need to overcome in order to move from one stage of the pathway to the next. So first of all, the assumption is that I can actually cook. If I can't cook, then no matter if I've got food to be cooked and all my friends are at the party, they're not going to be happy if I cook them really horrible food. So you can test this assumption in your formative research. And you might realise that actually I'm not very good at cooking, so I need to do an extra intervention, which is go on a cookery course or bring in somebody else who can help me cook. Because unless I overcome that barrier, I will not get to the next stage, which is the dinner is eaten. Once the dinner's eaten, I'm hoping that my long-term outcome, my kind of primary outcome of this intervention is that after dinner, my friends are happy because they've had a good meal. I can't guarantee that this dinner party alone will make my friends happy because there are many other things that make people happy. So my ultimate impact is contributed to by my intervention, but is not solely caused. The next thing we can do is add in rationales. This is the kind of evidence base for the pathway. So the rationale for why I decided to do this intervention at all was that there's evidence that eating good food makes people happy. And there might be other evidence that, for example, unless people accept invites, they won't come to your party. And then going back to the impact statement, as I said before, there are many reasons why people are happy. Relationship problems, work stress, etc. will all contribute. So you can add in this magic ceiling of accountability, which effectively says we are contributing to our overall impact, but we cannot be solely responsible for achieving it. We can be responsible for our long-term outcome, which is having happy friends after dinner, but we can't be ultimately responsible for overall making our friends happy. So once you've got the final pathway, you can add in indicators, and this is how you test we actually test the pathway, and this becomes the basis of your evaluation strategy. So for each of the intermediate outcomes and the long-term outcome in your theory of change, you add on to every step an indicator. So for example, whether dinner is eaten, we could weigh the leftovers and we could set a target that we only want 20% of leftovers, and anything under that would be considered that not enough dinner was eaten. Equally, for our long-term outcome of having happy friends after dinner, we might administer a wellbeing scale before dinner and another one after dinner and measure the difference in the wellbeing scale to see if the dinner had made people happy. Okay, so I want to pause there and see if there are any questions about the kind of overview of what theory of change is and the map.
Mary, I don't know if you can see this, but we had a question. Can you see the little comment box on your screen? If you can't, I can just read it to you.
No, I can't see it. For some reason, I'm not.
It just might be that you're sharing your screen so you can't see it, but I can read it. So we had a question from Ranadip. He asked what the definition of a complex intervention is.
Good question. So a definition of a complex intervention is something which has many Oh, I'm getting feedback now. Can you still hear me?
You should just keep going.
Okay. So the definition is an intervention which has multiple interacting components. So most healthcare interventions are complex. So even something which is technically simple, like giving an injection to a child, is actually very complicated because you've got to have the vaccination pathway through which the drug gets delivered to the child. You've got to train the health worker to deliver the vaccination. You've got to make sure that the vaccine is kept at a certain temperature. And you've got to make sure that you vaccinate enough people for it to have a population effect. So it's it's an intervention which has different components which all combine together. If that answers the question.
Great. Are there any other questions? You can either unmute and ask it or type it into the comment box.
Hello.
Yes,
It's
go ahead.
Ranadip here.
Yes, go ahead.
Yeah, that means intervention which has multiple components. Should we call that intervention is a complex intervention?
Yes, absolutely.
Okay, thank you.
Any other questions? Okay. So the next thing I was going to do was to take you through a real example of a real theory of change map. So obviously the example I gave you was slightly, was a very kind of simple overview. I would say in general, your theory of change should be simple. If it doesn't fit on a kind of 1A4 piece of paper, then it's probably too complicated for people to engage with. So the example I'll give you is, which is relevant to Saving Brains. It's a intervention that we've done in India and Pakistan to treat maternal depression using peer support workers with the aim of improving child outcomes as well as maternal health, maternal mental health outcomes. So the way we built up this intervention was first of all understanding what the actual intervention, what the problem is we're trying to address rather. So the problem is that mothers in South Asia, there's high levels of depression and there's currently very limited capacity in the primary care level to address their needs. There was a previous trial called the Thinking Healthy Programme run by Atif Rahman in Pakistan, which showed a very positive effect on maternal depression and child outcomes of community health workers, lay health workers delivering cognitive behavioural therapy to mothers. But unfortunately, it wasn't possible to scale it up into policy because the capacity of the community health workers to deliver this extra task was too limited. So the idea was that we needed to task shift even further down to peer support workers and to train peer support workers in the community in CBT techniques for them to provide support to mothers experiencing depression in their communities. So there are a number of barriers to implementing this intervention, such as the low numbers of trained mental health workers available, lack of knowledge within the community about depression, low help seeking for depression, and limited time and money for people with depression to travel to the secondary and tertiary facilities for treatment where there might be a mental health specialist. So we then thought of all different approaches that we could go through in order to address these barriers and to provide a treatment programme for mothers with depression in rural Goa. And I won't go through all the different lists, but it's basically this idea that we're task shifting from mental health workers to non-specialists, that it would be a community-based volunteer peer counselling, because there was the capacity in the community for those people to step up to be volunteers, and that we would use very low cost and short duration cognitive behavioural therapy. And that also we would combine that with community awareness to improve health seeking behaviour and reduce stigma. And that in order to find the women in the first place to be referred, we would use antenatal clinic staff for screening and diagnosis and referral. So I'm going to take you through the building up of this theory of change map, just reminding you of the different components of that map, which is these intermediate outcomes and long-term outcomes and impact, which forms the kind of backbone of the pathway. And then interventions which bring about each of the outcomes on the pathway. The rationale explains the logic behind each link in the pathway. The assumptions state the limits of the context you're working in, the barriers you need to overcome in order to move from one stage to the next. And then the indicators which measure whether you've achieved success, whether you've achieved that stage in the pathway. So building up the causal pathway then, the impact, the first thing you'd think of is what would the impact be, and our impact is to reduce the treatment gap for maternal depression in the district of Goa. And that impact, remember, is not something that we as a project can solely produce, but it's something which we are contributing to. It's the overall impact we are trying to work towards with other initiatives. And then the next step is to define what are the primary and secondary outcomes which we want to achieve with this project. And you can think of these as the primary and secondary outcomes of your evaluation, of your intervention. So firstly, we want to improve clinical outcomes for mothers with depression who are treated by the programme. And secondly, we want those mothers to have improved social functioning, and we want the child's health, the children of those mothers, to have improved outcomes, such as improved rates of breastfeeding and improvement in height, weight, for example. So now what we know we're trying to achieve, we can work back through the causal pathway of how we achieve it. So in order to achieve those primary outcomes, what we really need to happen is for the mothers to receive the counselling, the community-based CBT counselling, as intended for the required duration. So we're being very specific about the language we're using for that particular, for each of the long-term, for each of the intermediate outcomes. So it's not just that women get counselling, it's that they get the right counselling for the amount of time they need it in order for them to get better. So you have to be very specific when you word your intermediate outcomes. And the reason for that is then it becomes very easy to measure. So the Roman numeral number in each box is the corresponding indicator, which I'll take you through later on, which will show how you actually measure. But if you're specific about what your outcome is, what your long-term outcome is, then it's much easier to measure it. We can work back from that. So in order for the mothers to receive counselling as intended for the required duration, we need the PSWs, who are the peer support workers. The peer support workers have to be able to have key skills. They need to be able to deliver counselling. They need to be able to appropriately refer mothers to specialist care if the mothers are too ill in order to benefit from the community counselling. And they need to do community awareness raising activities in order to reduce stigma and to encourage women to join the counselling sessions. So we can now add on some intervention components. So the Thinking Healthy programme, THPP peer delivery, that's the actual intervention, it's the actual CBT counselling sessions. That's one component of this complex intervention. Another component is training. So in order for the peer support workers to have all of these skills to deliver counselling and refer mothers, etc., they have to be trained. And in order for them to be trained, we have to find them. So they have to be in post and they have to be integrated into the hospital system so that they can appropriately have people referred to them and also refer people on. You can see that we're building up a pathway here, and this is just one pathway of this complex intervention. So the next stage, working backwards, is in order for the peer support workers to be in post, we need to first have been able to find them. So we are using community health workers to identify, recruit and supervise peer support workers. So women from the community health workers will find them and recruit them. And these community health workers also have to conduct community awareness raising. And again, in order for those community health workers to be able to do all of those things, they need to be aware of the programme and they need to be trained. And then they can use, these community health workers can then do another aspect of the intervention, which is supervising the peer support workers. So these stars are all the different intervention components. So that's one pathway in our theory of change, where I've showed you how we've worked back from our impact to our primary and secondary outcomes, to the different intermediate outcomes that need to happen, and the interventions which are used to make those intermediate outcomes actually come about. The actual final theory of change, full theory of change, has other pathways. So these new boxes that have just appeared, these are showing the process through which in the antenatal clinics, mothers with depression are screened and referred into the programme. And then how those who are seriously ill, who have comorbid psychosis or suicide risk, are immediately referred out of the programme to receive specialist treatment. those who are in a suitable position to receive counselling are referred to the counsellors, and then we've got a cyclical referral cycle where if women don't improve after counselling, they're referred up to tertiary services, and people who recover are referred back down. So when I said about your theory of change can look any way you want it to be, this is an example of you can have cycles, you can have back pathways, you can have any kind of structure you want which reflects the reality of how your intervention works. So our ceiling of accountability shows that we are not actually going to be reducing the treatment gap through this trial, but we are going to be contributing evidence towards its eventual reduction. And that we have all of these intermediate outcomes in the pathway and only a few long-term outcomes. So another thing which is a real benefit, strength of using theory of change, is that we're not just focusing on the primary and the secondary outcomes, forgetting about all the process indicators that come before, by very clearly articulating the pathway which you need to go through to implement the intervention effectively. You are, by definition, outlining the process of implementing that intervention, and you're measuring the process. And actually, as you can see from this diagram, most of the points on the pathway are to do with process and not to do with outcome. Okay, so I'll stop there and ask if there's any questions about that.
Gertrude had a question from a previous slide, which you might have answered, but she asked, your intermediate outcomes seem to be the inputs. Is that correct? And then Gertrude, you can feel free to jump in. I don't know if her further explanation answered your question or not.
Thank you. I think the further explanation has clarified that, because I can see the intermediate outcomes start from the very, maybe at the beginning, where you have resources, and then go up to identification, because I imagine from resources to identification, you have more inputs. Then as you move along, then if we are using the area modes, the log frame, then you go to the primary outcomes. So the initial explanation to me was more of like inputs included in the intermediate outcomes, but this explains it further. So my question is answered.
Good. And you're quite right that this resources column does basically correspond to inputs on a log framework, where you need to have the people in post, you need to have the funding in place, you need to have the buy-in of the key stakeholders, and really those are the inputs, and without those the whole of the rest of the pathway can't happen. Same as for the dinner party example, you needed to have money to buy food, and you needed to have friends to invite, otherwise, which were your inputs, because without those things you haven't got the raw materials to make your intervention happen. Yeah, and then as you move further through the pathway, it changes into more process and then output and outcome. But instead of in a logic model where you have it very clearly delineated as an inputs, process, outputs and outcome, in a theory of change they can be in any order, because actually you might have the outcome of training might be much further down the pathway in a theory of change than it looks on a logic model. So it's a much more realistic representation of the actual order of things in a theory of change. Any more questions? Sorry.
Yeah, to pick up on that actually, Ranadip just asked, in a broad sense, is this the same as a logic model? So I don't know if Ranadip, you can also unmute and ask more of a question, but I don't know if what Mary just said answered that about the sequencing.
Hello.
Yes, go ahead.
Yeah. I think I have got my response from your previous response. But can you please explain me in a broad sense what is the basic difference between this theory of change and the logic model we usually use for evaluating a program?
Sure. So they're very similar. I would say theory of change is an evolution from the logic model. So it's like a logic model, but better. So the way it's different is that you don't have this very clear structure where you have to put all the inputs together, all the process stuff together. It assumes this very linear process, and actually in reality that's not the case. So you can still think of it as these are your kind of process indicators and these are your output indicators, but they might be distributed over the diagram in a different way than they would in a logic model where you have to put them in columns. The other difference is that a logic model often doesn't have indicators attached to every stage in the pathway. And as I'll show you in a minute, theory of change does, and that allows you to evaluate all the different pathways and therefore to disentangle which components of the intervention were most important or had the biggest effect on your outcomes. And the third way that it's different is that a logic model often doesn't have any assumptions on it. And if it does, they're kind of general assumptions about the whole project, rather than specific assumptions or specific barriers which happen at particular points in the pathway. And again, I'll give you an example of this in a minute as I carry on building up the theory of change.
Okay, thank you.
Great. Okay, so if there are no more questions, I'll continue.
So Gertrude has another question. How is the TOC different from a conceptual framework?
They're probably exactly the same. You can I think theory of change is a terrible name, I have to say. I would much rather call it a causal pathway. So it depends what you mean by conceptual framework, because that's a very broad term. But it's the same as a conceptual framework in that it's just a conceptual way of looking at your project in a visual way, which shows, diagrammatically how your intervention is implemented. But it has these extra layers, which we'll start layering on now in terms of the rationale, the indicators, the assumptions, which creates an overall picture of your whole project, which is just on one A4 sheet of paper, and which is used as the basis of not only designing your intervention, but also evaluating its impact. So I think it's a very structured way of doing a conceptual framework, basically. Okay. So building up these layers then, this is the pathway that you've already seen. And then I'm adding in now other parts of the pathway. So in order for this whole programme to work, we need an overall supervisor, who we've called an intervention coordinator, who ensures that there's adequate ongoing programme management and clinical supervision in place to make sure that all of the different activities take place. And that this person has specific intervention components that they do. So they have to be trained, and then they in turn supervise antenatal staff in the clinics. And then another layer is down in the community level. We also need the community to be aware of peer counselling, and then the mothers are willing to seek help and to receive treatment. In order to do that, we need to do awareness raising, community awareness raising, which the community health workers do, the antenatal staff do, and the peer support workers do. You can see feeding down into the pathway, into this intermediate outcome of community becoming aware, inputs from 3 different types of people who work on the programme. And then that has this feedback loop whereby mothers are willing to seek help and receive treatment, so they therefore receive counselling. And then when they've got better, the community sees that they're getting better, and then that feeds back into further improving community awareness and willingness to seek help, because as other mothers see people getting better, they will then be more likely to go and receive counselling themselves. So we can set up these different feedback loops, which again, a logic model would not allow you to do. It wouldn't allow you to have these kind of feedback loops and arrows going in different directions. And we would expect everything to be linear with no relationship between them. That's our final pathway. So this diagram is actually the final theory of change for the randomised control trial, which is going on in Go at the moment with the SHARE project. If anyone's heard of it. which is run by Vikram Patel and Atif Rahman. So that's quite easily printed on an A4 sheet of paper and perfectly describes what the intervention does and how it works and who's involved in it. So that's the kind of first purpose of the theory of change, is to provide a quick overview summary of exactly what your intervention is, which in itself is a very powerful tool to be able to quickly describe what you're doing. But then it's much more than just a description of your intervention. It then becomes layering up the rationale, the assumptions and the indicators, make it much more useful as a project tool. So first of all, the rationale. So theory of change is an evidence-based pathway, which means we need to show that we have evidence for why we think if you do something, if you do a particular intervention, it will move you to the next stage in the pathway. So the overarching rationale for why we think that if the mothers receive counselling as intended for the required duration, that they and their children will have improved outcomes, is this previous evidence from the Thinking Healthy programme trial in Pakistan, which showed exactly that in a similar population, just delivered by a different cadre of worker. Now, every step in the pathway could have a rationale on it, and that rationale might come from published research, but it might come from the experience of working on the ground, interviews with community health workers, for example, who say, yes, they've seen women come back and want to receive treatment when they've seen mothers improving. So it doesn't have to just be scientific evidence, the basis of the rationale. Common sense, evidence from the ground, anecdotal evidence is all completely acceptable when you're designing your intervention, because of course the purpose is to then formally test all of the stages in the pathway. So something that starts off as anecdotal evidence and the reason for testing this approach then would get turned into scientific evidence through the process of evaluating the intervention in your project. So the second layer is assumptions. So again, these are very specific assumptions which relate to barriers which would prevent you moving from one stage of the pathway to the next. So in this example, to have peer support workers who are in post has a massive assumption that there are women in the community in Goa with the qualities to be good peer counsellors and who actually want to volunteer to be peer counsellors in this programme. And that's a big assumption because it's a volunteer programme, you have to have very particular personality qualities to be a good counsellor. So we were quite worried that actually we wouldn't find any women who actually wanted to volunteer to do the programme. So this assumption then becomes something which you take forward in your formative research to test. So before you formally finalise your evaluation and go and test it in a formal evaluation, you would actually go and do your formative research to test whether these assumptions are correct. And if they're not, you have to change your intervention to match it. So another example of an assumption from this project is that mothers are willing to have counselling from their peers. And again, this is a big assumption that a mother would be happy to share their deepest, darkest thoughts with effectively another member of their community. And we were very worried that this might not be the case. So again, in our formative research for this trial, we tested this. So we did qualitative interviews with mothers in the community, with mothers who had depression, and we worked out what the qualities would be for people to be good peer counsellors, whether enough people existed who wanted to volunteer, and whether mothers would be willing to receive this counselling. And it turns out that in Goa, they wouldn't be happy to receive counselling in groups, but they would be happy to receive one-on-one counselling. And so we changed the intervention to be individual level counselling rather than group counselling. And then the last layer is indicators. So an example of an indicator for this project is firstly for our primary outcome, a 50% improvement in depression symptoms and social functioning scores at 3 months. So this is what you do your sample size calculations on for a trial. What's the actual level of primary outcome improvement that you're looking to see? But that's just the outcomes. We then need indicators for every other intermediate outcome in the pathway. So, for example, we worked out that we needed to have 6 peer support workers in the trial in order to have enough peer support workers to counsel enough women that we needed in the trial. So we set an indicator to recruit 8 peer support workers on the assumption that some would drop out and some might not have the skills after training to be good peer support workers. So we wanted some flux in the system, so to speak. And then another indicator, as an example of a process indicator, is that we wanted to make sure that at least 80% of the women who attended the antenatal clinic were screened, and that of those who were screened, 80% of them who were diagnosed were appropriately referred. So we're setting targets at each stage in the pathway, which shows what its success looks like, and then you can measure whether that success is achieved. And when you go to evaluate the whole pathway, you can see where the gaps were. So, for example, we might find that actually antenatal screening worked really poorly and only 50% of women got screened, and they missed the women who were most likely to have depression, and therefore not enough mothers were coming through the system into the counselling. So it enables you to untangle what actually happened. And of course, you would add indicators for every stage in the pathway. And then once you've got your complete list of indicators, that then provides you with your evaluation strategy, because you would say, for example, these indicators I can measure through qualitative interviews with women, these ones I can measure through looking at the records of the antenatal clinic, this one I need to do a cohort, for example, of mothers to measure the change in their outcomes and the change in the outcomes in their babies, or ideally do a randomised control trial to assess that. You can package together your indicators into groups of study designs, which you then implement as your evaluation strategy. And then obviously you get approval for, for all of this from your stakeholders, which I'm going to take you through in a minute. I'll pause there again for any questions about that. No? Everyone happy? So strange not having a room. I normally look around a room and get a thumbs up, but this is weird. Okay. So hopefully that's given you an idea of what a theory of change map is and how to construct one. I now want to take you through the process of how you actually become a theory of change champion for your project. So the actual kind of process that you go through in order to create this map. So the main process which we recommend is a theory of change workshop. So this is at the beginning of your project, you would gather together all of your key stakeholders into a participatory planning process. And this is just the same as what you would probably do anyway, where you would have meetings with your stakeholders and have a participatory planning process anyway. So it doesn't supersede any of that. It just gives a structure which you can use to guide the discussion. The exact format that you have your workshop in is completely up to you. It should be completely dependent upon context and the people you've got in the room and how you know it will work in your setting. There's absolutely no prescribed rules. The only set thing is at the end of it, you should come out with some form of a map which the stakeholders have bought into. It's really important to include a very wide range of stakeholders in your workshops. So in our example of the peer support worker programme, we included psychiatrists, paediatricians, the district health planners, midwives, antenatal clinic staff, mothers with depression, community health workers, other members of the community, basically everybody at all levels who is involved, who would be involved in delivering the intervention and who has knowledge which can help you design an intervention which would work in the context. And that's obviously why you end up with a much more context-specific intervention. Depending on the setting and the kind of politics of different stakeholders, you might decide to have different stakeholders in different workshops. So we quite commonly have workshops, one workshop where you might have the district level health planners and the paediatricians and the psychiatrists, and then another workshop where you might have the community health workers and the primary healthcare staff, and then another one, perhaps even if you might have people with mental health problems in that workshop. So, and that's purely because of obviously the hierarchies of power. You know, a mother with depression might not feel comfortable speaking up in a workshop with the district health planner, for example. But again, that's completely up to you how you run your workshops. The most important thing is that you draw on a diverse range of knowledge so that everybody's knowledge is important, and it's not that somebody says, oh, I read in the Lancet last week that this will help kids. It's that the community health worker says, actually, I know that mothers will not want me to counsel them in their house because their neighbours will think that there's something wrong with her, and it'd be much better to do it in a clinic environment where she can pretend she's going in for something else. So all knowledge is important, and all knowledge should contribute to creating the rationale for your theory of change map. And the last thing is that the facilitator is key. You as the kind of theory of change champions for your project is the only real person who needs to know about theory of change and what it is. Everyone else in the workshop doesn't need to know what a precondition is and what an indicator is or anything, because you as a facilitator are the one building the map on the wall. The way we normally do it is you get lots of different post-it notes of different colours, and you have a different colour for each type of thing. So, for example, all intermediate outcomes would be orange, for example, or indicators would be blue. So you can build up the map. And it becomes very clear. It's such a logical process that people don't need to know about the actual process of doing a theory of change, because you're just gathering their ideas and representing them visually on the wall. It's hard work being a facilitator. You have to have your ears open and your writing skills, and it's an intensive process. But it does mean that you can have everybody, all ranges of stakeholders, and they don't need any additional training to attend. Obviously, you can tell them about it if you want to, but it's not a requisite. So the facilitation skills that you'll need to run your workshop, as I said, you're the only one that needs to be the expert. It makes sense if you then become the theory of change champion for your project. And across the different projects that we've done theory of change in, and drawing on other people's experiences, it does seem that a critical factor of success of doing a good theory of change is to have a champion whose role it is within the project to kind of to champion the use of theory of change. So they would be the person who's trained, they would be running workshops, they would be responsible for revising the map, feeding in the indicators into the evaluation plan, for changing the theory of change map as the project progresses and you learn new things and you realise the pathways have changed, and ultimately for revising the theory of change at the end after the evaluation to reflect the actual reality of how the intervention was actually delivered in the real world. And the kind of qualities you need to be a good champion and a good facilitator is you need to be very clear in your verbal instructions. You need to be very organised, focused and fair. In that fair means that you let everybody in the room speak and you accept all forms of knowledge as valid. So some of the challenges of running a workshop, it's by no means easy. Getting stakeholder buy-in is a challenge of any participatory planning process. We found it's a very useful tool for getting stakeholder buy-in because you're starting with a blank sheet of paper effectively, and most of the time the only thing that's on the wall is what your impact's going to be, and then your kind of broad idea of the actual intervention you're going to deliver to get there. So for the dinner party example, we knew we wanted to make happy friends and we knew that we were going to have a dinner party to make them happy. The actual details of how that dinner party was going to run, what was going to be cooked, who was going to do the cooking, who was going to be invited, all of those things were up for grabs as a discussion point for the stakeholders creating the pathway. So it enables people to feel much more engaged than if you present them with a fait accompli of what you're going to do in your project. The other difficult thing to manage is obviously group dynamics and politics, which are completely context specific and can't be ignored. And again, how you set up your workshops, who you have as facilitator, who you invite to the meetings are, critical things that only you can decide based on the context that you're working in. So another real challenge is it's actually hard to manage group expectations to create something very realistic for the people working in. So one workshop we did recently with people with severe mental health problems in Uganda, they had the most fantastic ideas of what they wanted to achieve with this project, but the realities were it was a very poorly funded project in a very under-resourced psychiatric hospital in Uganda, and the reality of what this project could achieve would no way near met the expectations of what the patients wanted the project to achieve. So that was a very difficult process of kind of letting people down slowly. The other flip side of that is that it's a very good way of managing stakeholders' expectations, particularly expectations of Ministry of Health officials or district health planners who think you might be able to come in and magically change things. A good example we've had of that was in a project I worked on in Nigeria, where we wanted to have a certain number of health workers who were delivering mental health care and primary care. And it was all paid for by the Nigerian state government. And when they realised that actually, in order for the project to have the impact, we needed to have one person in every primary healthcare facility who'd been trained. And when they added up the numbers of how many people that would mean actually training, they suddenly got massively cold feet and said, oh my gosh, we actually can't train 50 people across the district. And so then we had a very honest and open discussion to say, well, okay, if you can't afford 50, how many can you afford? Okay, you can afford 25. That means every other clinic is going to have a mental health specialist, which means that only half the number of people are going to get the coverage of the treatment than what we'd hoped for. And then we redesigned the intervention instead to only put these people in the bigger health clinics and to make it clear that actually the higher level health clinics were the ones that had mental health care and basic primary care wouldn't have it. So that was a very good and positive experience where very quickly and very early on in the process of designing the programme, we redesigned it in order to be realistic for the Ministry of Health and also at the same time reduced their expectations of what the project could achieve because they didn't have the resources to implement what was needed to get full coverage across the district. Another challenge of the workshop is when you have multiple workshops. So if you're breaking your workshops down into different groups of stakeholders, you have to still come to a consensus map at the end of the process. So the way that we've worked out the best way to make that consensus happen is start with your the kind of highest level stakeholders. So start off with the Ministry of Health people, for example, and get their broad agreement on the project and map out the basic structure of things. And then take that to your primary healthcare workers or your community health workers, whoever is actually going to be delivering the intervention, and present it to them, but leave the detail up to them. So, how many, what kinds of tasks are you happy doing? How many days a week can you actually dedicate to this? Those kind of more managerial decisions, ask them about. And then take that back to the higher level stakeholders in order to get their buy-in. And in that way, you're taking the map through the process of multiple workshops rather than creating different maps and different workshops, which you then can't reconcile. And then obviously the last challenge is the challenge with everything, which is time. Ideally, you would have at least a couple of half-day workshops. And that obviously requires your key stakeholders to be available for 3 or 4 hours at a time. It's not really, you can't do it in an hour. You need a good couple of hours to do it, and then revisiting it again in another good couple of hours. So you do need enough time from the key stakeholders. And then the last thing is, once you've created this map towards the beginning of your project, you'll have your map, and you might want to write a narrative summary of your description of either the process, which then you can publish, or you can have a summary of what your map describes. And then you take this map, it doesn't become a fixed thing, the map. The map then becomes a living document which you take through your whole project. You refine it through the process of formative research. So you test all the assumptions, you add in new interventions if you need to, you adjust ones that didn't work very well, and then you formally evaluate it, and then you review the theory of change based on the results of your evaluation to produce your final theory of change. And that's how it becomes a useful tool throughout the whole project. It's not just at the beginning to design your intervention. It's used through the formative research and through the piloting. And the refine and evaluate bubbles that you see there in the next webinar in the middle of September, I will be taking you through the process of how you take your theory of change that you've developed early on in your project and you refine it through a process of formative research and evaluation, and then you take it forward to the formal evaluation and how you actually use your indicators to create an evaluation plan. So that's all I was going to present on today. I think we've got some time for questions. Yes, lots of time for questions. So.
Yeah. So we had we have a couple of questions in the queue already. 2 questions on assumptions. So Gertrude said sometimes the assumptions may be too many. What do you do then? Do you abandon the intervention? And then related, Renadip asked, it's an interesting concept, but there are lots of assumptions. And what if the evidence from the literature is not strong? Are there any statistical techniques involved?
Sure. So very good questions. The real answer, what you should really do if you find you have too many assumptions, that suggests your intervention won't work and you might want to reevaluate your whole intervention. One of the good things about theory of change that is also a scary thing is that very early on in your project, you come up against the barriers you're going to face and you're forced to decide what you're going to do about them. Are you going to try and overcome the assumption by changing your intervention, or are you going to effectively say, well, that method probably isn't going to work because there are too many barriers? What normally happens, what's happened in the past, is that you find out those assumptions at the end of your project when it doesn't work, and you try and work back to find out what didn't work, what went wrong. So by very explicitly at the beginning seeking out the assumptions and testing them through formative research, you should be able to adapt your intervention to make it better right from the start before you formally evaluate it. Can you repeat the second question, Dan?
Yep. And then so Renadip said, what if the evidence from the literature is not strong? Are there any statistical techniques involved to perhaps eliminate some assumptions?
Sure. So when I say that you take the theory of change through the whole project and you refine it as you go along, at the beginning when you first do your theory of change, you're going to have loads of assumptions and you're not going to have strong rationale, because by definition, you're doing something innovative and there probably isn't a lot of good evidence around already which shows that your approach is going to work, because otherwise you wouldn't have got funding to test whether it was a good idea or not. So don't worry if you've got lots of gaps in your rationale, but by having good indicators across your pathway, by the end of your project you should have generated that rationale because you're empirically testing the whole pathway. Obviously, if a lot of things don't require formal rationale, so for example things like some things are just obvious. Like if you, I'm trying to think of an obvious example. You don't need scientific evidence to show, for example, that you need money to be available in order to start a project. That's just common sense. So you don't need to have a rationale for every single link in the chain. But the critical links in the chain, like why do we think that if the people receive the intervention, they will have improved outcomes? If there should be some form of formative evidence which suggests that that approach is a sensible approach to take. Or, for example, the type of training that you deliver. If you're doing very didactic training and there's evidence that actually people are only good counsellors if they have real hands-on experience, then you should use that in order to make the training part of your intervention the most appropriate for the context that you're working in. So don't worry about not having brilliant rationale at the beginning, but make it your mission to gather that rationale throughout the process of your project by having very good process and outcome evaluation. In terms of statistical tests to evaluate the whole pathway, I was going to cover that in the next webinar, and that the basic answer is that there are no set tests you can use. Some things like structural equation modelling might be a very useful thing to do, which would actually show you the links in the pathway and the strength of the different pathways. But you basically use the same research methods and the same statistical analysis methods you would for any other evaluation. All you're doing is putting those methods onto this framework which give you this overarching picture of what the intervention is doing and how it's achieving its impact.
And, following up on that, is SEM involved?
Yes, that's structural appraisal modelling. Excellent thought, yes. So I should say, I mean, being brutally honest with everybody, I first learned about theory of change about 2-3 years ago, and it wasn't really used in research before very much. So I've spent a lot of the last couple of years developing how you actually use it to be part of research, and particularly how you use it in conjunction with the MRC framework for evaluating complex interventions. And I hope we can circulate some links to some resources around that, and more resources on theory of change, which are all on the Mental Health Innovation Network. So in none of the projects that I work on have we got to the final stage of actually evaluating the whole pathway. So I'm being brutally honest, that though I think structural appraisal modelling will be a great approach to use, I haven't seen anyone do it on theory of change before, and I haven't done it myself.
Great. Switching gears, Darius had a question about what determines the weight of a good TOC. Is it number of outcomes or participants? What if it isn't that big? What if it's small?
So you cut out the last bit. What was the last part of the question?
So basically, what makes a good theory of change? Is it the number of outcomes or participants? And what if the theory of change is small? So does that matter?
I like small theory of changes. I think, to me, a definition of a good theory of change is if you can look at it and in 5 minutes you understand what the project's doing. If it's a massively complicated with arrows everywhere and a million boxes, then that's not a helpful resource. It produces too complicated an evaluation, and it's not a useful dissemination tool. So I would say clarity is the most important thing, that you can look at it and see what it's trying to achieve and how it's achieving it. That's obviously balanced between the usefulness of theory of change for the project as a project tool and as a dissemination tool. And some of the more complicated projects I work on, we sometimes have two theories of change. One is a very detailed, or more detailed one, which has perhaps more broken down pathways in it. And then we might produce a summary theory of change, which might only have, 7 or 8 boxes on it. And it would be the summary theory of change which we would then disseminate to describe the project, and the project level, more detailed theory of change we might use within the project team. But I have to say, in the cases where we've done that, we almost always discard the more complicated theory of change and end up working on the simpler one. Just because it didn't make sense to subdivide stuff when actually you could lump them and make everybody's life easier. So clarity, I think, clarity and simplicity is the most important thing. And clarity of language, so the way you word your intermediate outcomes is really, really important, so that people can read it and say, okay, so that means people have the skills to deliver an effective intervention. People get the intervention as intended, therefore they get better. The language should logically lead on from each other.
Great. If anyone else has questions, you can either type them into the comment box, or you can unmute and just ask them straight to Mary. We don't have any others in the queue right now. So.
Mary, this is Anu, and everyone. This is Anu Rajashankar. I'm a member of the platform team as well at Harvard School of Public Health, and I thought this was a very nice presentation, and I was wondering if you could just highlight, again a bit more about how this is really a dynamic process, and the grantees should be expecting to really keep track of how things are changing, and this is really helpful as a guide for them to be able to understand that what they originally had attempted to do or were planning on doing, in fact, may not have been effective or appropriate, and that's okay. And this is a way to guide them through that process so that they have the goal is always there, but the process may actually change.
Absolutely, yeah, that's absolutely right. And And I always think about it, it's not what you do, it's what you achieve that matters. And if you have to change what you do in order to achieve what you're trying to achieve, then that's fine. And as long as you're documenting the process of the decisions you're making and the changes you're making to the intervention, I think that's really valuable information, not only for you going forward in other projects, to understand what did and didn't work, but also for other people so that they don't reinvent the wheel for things that haven't been that effective. Yeah, I always, and it's a very tempting thing when you run workshops, people instinctively want to say what they want to do. So they start talking about, oh yeah, let's immunise kids and let's train people and let's, you know, go and distribute drugs. But actually they're the intervention components, and what you should be thinking about is what are you trying to achieve at every stage in the pathway, which is that people receive the right intervention and are adherent to that intervention, and people have the skills to deliver the intervention. Yeah.
That's helpful. Thank you.
Right. So any other questions, or you going to have a cup of tea?
Yeah, I think we'll close this. As a reminder, we do have a Q&A next week to answer any additional questions you thought of. Mary won't be there, but the platform team will be there to talk about this more. And then, as some of you will have seen in the notes, our next webinar that is on an actual topic will be on August 19th, and that will be thinking about measurement. And just as a quick note, all of the webinars, I think we might be moving one, but basically it's every Wednesday, and they start at 9 a.m. Eastern US time. So the same time that this one started today, they should all start at that time. So it should hopefully be pretty easy to get in the schedule and the swing of things. Yeah, so we will see you hopefully next week at the Q&A, and then in 2 weeks to talk about measurement.
Well, thank you, everybody. Yeah. Thank you very much, everybody, and thank you very much. Wonderful and polished presentation for us. Really lovely.
Thank you. It's lovely to meet you all virtually.